Good afternoon. Thank you for joining the ACR for our second webinar in our QCDR series. Today's title is Strategies for Identifying Measures and Activities Using the QCDR to Satisfy MIPS. It's a mouthful. Today's presenters are myself, Alicia Blakey, and Zachary Smith. We will walk you through how some important elements and considerations for quality measures, as well as improvement activities. We did receive a few questions about the ArtScan project. We will cover that in great detail on today's webinar. Just as a few housekeeping notes, everyone is in listen-only mode. We do want you to be engaged and active, so please do submit your questions. I'm surrounded by my colleagues who can respond to some of your basic questions as I present. And then also, today's presentation slides as well as the webinar recording will be available to all attendees who registered or attended our session today, as well as will be posted on our QCDR website. I see a number of you are still joining the conference, so the first few slides will talk about what we will cover today. This webinar is designed to walk you through each of the MIPS performance categories, as well as tools and resources to help you navigate our qualified clinical data registry. We understand it's a broad audience joining us today. Not everyone is aware of the QCDR and what it is, as well as we do have some people who are still trying to make that transition from claims reporting to registry. So we hope that this will at least set some precedent to help you decide if the QCDR is right for you. At the conclusion of today's webinar, participants should be able to understand the difference between MIPS and non-MIPS quality measures, use ACR web-based resources to select measures and activities to comply with MIPS, and then assess your practice ability to meet data submission requirements using a QCDR. When we talk about the MIPS program, it is part of the MACRA legislation, and in most of our webinars, we're going to make sure that we give you this MACRA participation checklist, because in addition to deciding if you would like to use a registry to report your quality data, there are also a few other considerations, one being the patient-facing status of your clinicians or your group, identifying if you're a hospital MIPS eligible clinician. If so, there are some special considerations for you related to the advancing care information. And then today's, so this full list is here for you as a guide of all of the things that you need to consider, primarily if you are going to report as an individual or as a group. Today's presentation will focus on the third bullet down from the bottom, review 2017 measures and improvement activities, and understand the reporting requirements. So what is a QCDR? We are a qualified clinical data registry. We are one of many reporting mechanisms for satisfactory MIPS participation, and we are distinct from a qualified registry. Part of the QCDR is making use of the ACR's existing registries. The second bullet, all QCDRs, we are not the only registry vendor. It is CMS and a CMS approved entity that collects medical and or clinical data for the purposes of improvement in the quality of care furnished to patients. Quality data submitted to a QCDR must include patients across all payers and is not limited to Medicare beneficiaries. Another important element of the QCDR is that we do we develop our own quality measures as a specialty society that are specific and more applicable to radiologists, and these are coined as non-MIPS measures. Lastly, QCDRs can submit quality measures, or anyone who is using a QCDR, the essence is that you will report your data to a clinical data registry, and we will package that information and submit it to CMS, whether that be ACR or any other vendor you have worked with in the past. For 2017 reporting, the QCDR has the capability to report quality measures, improvement activities, and advancing care information measures to CMS on behalf of its participants. So please keep that in mind. The common question that I get is, will the QCDR be able to report my improvement activities? And the answer to that question would be yes. I think it's important, because we have such a broad audience, that we discuss some of the benefits of using a qualified clinical data registry. We support both individual physicians and physician group practices in meeting the requirements. We manage submission of all 3 MIPS performance categories. And as I mentioned previously, the ACR's QCDR, we have measures called non-MIPS measures. They are developed by ACR and may be more meaningful and applicable to the care radiologists provide. So if you participated in PQRS in prior years and you were not able to find enough quality measures to meet reporting requirements, the ACR has taken that additional step to build that measure portfolio. We provide direct assistance in compiling all the needed data for your quality improvement. Our goal of the registry is that, in addition to submitting data to our registries, you do make use of our feedback reports, that we actually have them on a quarterly schedule so that you can monitor radiation exposure, cancer detection rates, et cetera, so that you may make any changes in your practice patterns as applicable prior to the CMS submission. And then lastly, we allow physicians to review and select measures to report prior to the CMS submission deadline. So transitioning just a little bit to speak to the essence of the Qualified Clinical Data Registry, the main element is really making use of our National Radiology Data Registries. We have 6 data registries, and they're all listed here for your viewing. And each registry actually will have anywhere from 2 to 6 quality measures that can be used to satisfy the MIPS quality performance category. So we do, as a QCDR, that's an entity name that we're given by the government, but we do want you to know that to get started with the QCDR process, you do need to be participating in our NRDR data registries, 1 or more if you have the capability to do so. We'll jump right into the first performance category. Today's is talking about strategies for selecting quality measures. So the MIPS performance category is quality, and it's weighted at 60 to 85% of your total MIPS score. QCDR participants are allowed to report a combination of MIPS and non-MIPS measures for successful MIPS participation. So if it sounds like I'm being a little repetitive, I'm just making sure that I emphasize certain points so that people are aware that the QCDR does operate from your claims reporting options as well as your qualified registry participation. And then it's very important that non-MIPS measures are chosen from across all 6 of our NRDR data registries that we just viewed on the prior slide. For the quality component category, primarily the goal that everyone is trying to achieve is to report up to 6 quality measures. And of those 6 quality measures, at least one of them must be an outcome measure. Not to worry, if you do not feel that you have an outcome measure, you can report a high priority measure instead. For this category, there are 6 quality measures. For each quality measure, you can earn anywhere from 3 to 10 points per measure. And bonus points are available if you go above and beyond the 6 measures and 1 outcome that's required. Very high level, if you were to report 2, let's say, for example, 2 outcome measures, you would earn 2 bonus points for each additional outcome measure that you report above the 1. For 2017 reporting, all of the quality measures by CMS, they've identified which measures are considered high priority. And so if you do report a lot of measures that are high priority, you will get 1 bonus point extra. And then there's additionally a bonus point if you are using certified EHR technology and submitting your data either to a clinical data registry or to CMS directly. It's called kind of end-to-end reporting. You could get one bonus point. I do just want to highlight that although bonus points are available, they are based on performance on your measures, and it has been capped at 6 points for this performance category. And then the total possible points available in this slide, it does say 60 points. I will ask those who are doing a group practice reporting option or G-Pros, groups may have one additional quality measure related to readmissions that does not require you to report any additional data, but it'll be processed using adjudicated claims. So there wouldn't be anything that you need to report. But if you do have that readmission measure for your group, I think it's applied to groups that have 16 or more clinicians. You could have anywhere from 60 to 70 points available. Looking at our portfolio of the MIPS quality measures that we actually support here at the ACR, we have anywhere from we have about over 50 quality measures that can be reported for a radiology group or individual clinician. We do have measure documentation on our website outlining which measures are applicable based on your specialty area. So this is a screenshot of that exact document. We tell you what the quality measure is, whether or not it's a high priority or not. If we look at 145, it has 2 exclamation points. And then for 146, it has 1 exclamation point. Anytime you see an exclamation point 1 or 2, that means that that is a high priority measure, and there's a code at the top for you. We also want you to pay attention to if your measures are inverse or not, and then what domain category they fall under, as well as the measure type. Is it a process measure or an outcome measure? Most of the CMS MIPS quality measures are process-based measures. The outcome measures really come into play if you're an interventional radiologist or you use any of the ACR clinical data registries, because most of those measures, because they're developed by us, they are specific clinical outcomes. So this just gives you a snapshot of the MIPS measures that are available. As I mentioned, there are over 50 measures. To maximize your quality performance category, you want to focus in on outcome measures and high priority to get max points. And then most importantly, in our measure documentation, we link to the CMS measure specifications that tells you the numerator, the denominator, what particular codes need to be included in your records, as well as what constitutes performance met versus performance not met. So we did want to go through Measurement 101 for this audience because we know you guys have been doing this for several years, long before the QCDR. I think it's important to transition to, as I mentioned, with the QCDR, you can report quality, MIPS quality measures as well as non-MIPS quality measures. Non-MIPS quality measures are developed by the ACR and may be more meaningful and applicable to care that a radiologist would provide, which means if you are using a qualified registry in the past, these measures would not have been accessible through that reporting mechanism. You must use a QCDR. The start of using a QCDR is participating in our NRDR data registries. This next bullet are 2017 non-MIPS measures. This list of measures, as we just looked at with the MIPS measures, those are all approved, but the 2017 non-MIPS measures are pending CMS approval. We anticipate that they will be releasing this list in the next few weeks. And then all of these measures will span across all 6 of our NRDR data registries, and these will be very similar to our 2016 non-PQRS measures. If anyone has participated in the QCDR in the past, you are aware of the non-PQRS measures. Our hope is that we will continue to offer those same measures for 2017 reporting, but there may be some slight changes. This is a quick snapshot of what our non-MIPS quality measures list would look like. We would identify the measure title, the description of the measure, as well as letting you know if it's a process measure or an outcome measure, and then how CMS has categorized that measure. Prior to 2017, domains was a huge requirement. It is not a huge requirement currently, but keep in mind that the domain will help you potentially identify high priority measures. If you look at the descriptions of some of these measures, I'll just pull out one example, the screening mammography cancer detection rate. For anyone that's following along, it's the third measure on the list. This is meant to look at the fraction of all screening mammograms that are interpreted as positive and have a tissue diagnosis of cancer within 12 months. And this is a clinic, an outcome-specific measure that is developed by the ACR. And because it's related to mammography, how you would get access to this quality measure is by participating in the National Mammography Database. So please keep that in mind. The list is pending CMS approval, and we will hope to release that very soon. So for our proposed non-MIPS measures, as I mentioned, we have six clinical data registries, our measures, as well as the overall QCDR approval is pending CMS approval. And here's a breakdown of measures that we've proposed to be available for each registry. So no surprises here. We are offering 26 quality measures, up to over 20 measures for the non-MIPS category. Our newest registry, the Interventional Radiology Registry, obviously this is designed to promote quality of care for patients undergoing IR procedures. We potentially have up to 6 quality measures that could be reported. It may be 5, it may be 4, but just be aware that there will be measures available if you're participating in that IR registry option. So that kind of summarizes the quality category, understanding that you must select 6 quality measures. Try to be direct in which quality measures you want to report. You want to focus on outcome and high priority if you are interested in getting bonus points. The next category, so we're going to shift to the advancing care information category. This is also a part of MIPS, and it gives you anywhere from 0 to 25% of your MIPS overall final score. This category is meant to support the exchange of health information and the use of certified EHR technology. This does, in fact, replace the Medicare EHR incentive program or meaningful use. So that's the top question right now. What people are trying to make that transition, especially for radiologists. Some of you all have had the hardship exemption. I do want you to be aware that although with the advancing care information category, there is some potential for you to have that exemption automatically and not have to apply, but we'll get to that a little bit soon. So based on participation in this category, you're going to have a base score of 50%, a performance score of up to 90%, and a bonus score for using EHR technology end-to-end reporting, I believe. The minimum reporting period for this category is only 90 days. So just keep that in mind. If you are required to do the advancing care information category, it's looking at a 90-day reporting period. As I mentioned, bonus points are available for registry reporting and if you use a certified EHR technology as an improvement activity. So here's the bullet that's most important to our radiologists and our community, is that exemptions are automatic. Although this is 25% of your MIPS final score, it is weighted at 0% for any provider who is a hospital-based clinician, meaning that 75% of your services are in care settings of, we put it here, outpatient settings, some campus settings, et cetera. So place of service codes 21, 22, and 23. And then very important, in the participation checklist that we showed in the beginning, we said providers need to be watching and their managers need to be determined if you're patient-facing or non-patient-facing clinicians. If you are a non-patient-facing clinician, this category is weighted to 0%, and that 25% 100% will be assigned to your quality category. So that means that if you are a non-patient facing clinician, your primary category will be quality and improvement activities under MIPS. So that's where you should spend most of your efforts. If you are a patient-facing clinician based on your group or based on the services that you provide, you have patient-facing encounter codes that you bill Medicare for, there is an opportunity for you to apply for an exemption. And listed here at the bottom of the slide is just 3 reasons of why you would not be able to satisfy the advancing care information category. I tried to put this together as just like a quick snapshot. This is not my strongest area, but if you do have particular questions, go ahead and send them in the chat feature and we'll try to answer where possible. If you are a patient-facing clinician, as I mentioned, some of your score is based on a base score and a performance score. So in order to get any sort of credit for the performance score, you must satisfy a majority of the components for the base score. So 4 out of the 5 base measures are required if you want to do well in this category. You'll see the objectives as well as the ACI measure here for you. And then the last column is really important. What type of data would you need to satisfy for this category? It would be a yes or no attestation type statement, or in some instances, you will need to supply the numerator and the denominator of your eligible patients. So keep in mind, as just circling back to what we said previously, the QCDR will collect your quality measures, your improvement activities, as well as your advancing care measure information. We are building functionality to satisfy all 4 of the MIPS categories, but a majority of clinicians should be exempt based on the non-patient facing status. So I'm going to transfer, that's the end of my talk. We're going to look at improvement activities, and Zach's going to give you some details of what you need to look for. As well as, please do stay on the line because we will be also doing a live demonstration.
Hello, this is Zach Smith, and I'm going to talk to you for a bit about the improvement activities category. So unlike the quality and ACI categories, the improvement activities is a brand new program under CMS. It's not descended from a previous program. And what it is basically is a requirement for physicians or groups to attest to participating in various quality improvement activities in their practice. And like ACI, the requirements do differ whether you're designated as patient-facing or non-patient-facing. So for improvement activities, you're going to be required to attest to completing up to 4 activities for a minimum of 90 days. So for patient-facing clinicians, they're going to have to have completed either 4 medium-weighted activities or 2 high-weighted activities. But for groups with fewer than 15 participants and for non-patient-facing clinicians, they'll only have to do up to 2 activities. That would be 2 medium-weighted activities or 1 high-weighted activity. And you can see some links below here. When we send the slides out to everybody, you'll be able to click on these links. The first one here, the MIPS improvement activities. This is a list of all the 93 different MIPS improvement activities, including notes that we've made on which ones we've suggested for radiologists. And then we've also got a link here to the CMS improvement activities fact sheet, which is going to include some more in-depth information about choosing activities and the reporting criteria for them. This next slide here is a screenshot of our improvement activities spreadsheet. Now, again, you can find it on the previous slide, or you can find it on our QCDR webpage. That's just acr.org/QCDR. So this is, again, going to show you all the, I believe, 93 different improvement activities. It's going to show you the subcategory they belong to, and in this screenshot, we've got achieving health equity, beneficiary engagement, care coordination, but there are a lot of different subcategories. It's going to show you the activity names, the activity descriptions, along with their weight, either medium or high. We've also got columns added. I'm not showing them on this slide here, but we've got columns with the suggested documentation and validation information that CMS recently came out with. So they've provided some guidelines for how to report this information to them. Now, if you look at the activity names and descriptions, you'll notice that a lot of them are written to be fairly open-ended. You'll see, for example, use evidence-based decision aids to support shared decision-making, improve practices that engage patients pre-visit, collection and follow-up on patient experience, and satisfaction data on beneficiary engagement. So these are all written to be kind of open for interpretation. The idea is that there are probably several different activities you could do that would meet the guidelines for some of these improvement activities. And so speaking of available improvement activities for radiologists, we'd like to take a minute to talk about the ArtScan program. Some of you are probably familiar with this already, some of you might not be, but this is a new program that ACR is working on that's funded through the CMS Transforming Clinical Practice Initiative. So ArtScan stands for the Radiology Support, Communication, and Alignment Network. Now, it's a totally free web-based tool, and the objective of it is to provide a framework for referring physicians and radiology groups to get together and collaborate on a quality improvement project. So in a nutshell, ArtScan involves looking at retrospective ordering data and trying to identify some patterns of maybe inappropriate imaging or image overutilization. Next, there's a process of educating the referring clinicians about appropriateness criteria using some free CME materials that we provide on the ArtScan website. And then finally, looking at post-education ordering data that was done, after the educational program, and using that to evaluate some kind of improvement in your ordering practices. And again, this is 100% free to participate in. You just need an ACR login, which anybody can create for free. So we've got a link here, but it's just artscan.org. So ArtScan was approved by CMS to meet 7 different improvement activities. So that means if you complete a whole project, which would probably take a few months at minimum to complete, but if you can attest to completing an ArtScan project, that would make you eligible for several different improvement activities. Again, the most anybody would have to complete is 4. So completing one ArtScan project would count as all of the improvement activities you need. So pulling together everything that Alicia and I have talked about, here are the steps to making sure you're meeting your MIPS requirements. You're going to want to understand the different MIPS performance categories and their requirements. Select the appropriate measures and improvement activities to maximize your performance. Use ACR resources to submit your data. And then when it's all said and done, CMS will calculate a final score for clinicians or groups based on performance across all categories. And they use that score to determine whether you get a positive or negative payment adjustment. And we've also got a link here for the new CMS eligibility lookup tool. That's going to help you determine if you are required to participate in MIPS or not. And again, you can see this graph here on the left, which shows a breakdown of the 3 categories. And here's a table we've made to show the different weights for patient-facing versus non-patient-facing clinicians. Again, quality is the main category affected, which is 60% of your total performance score for patient-facing clinicians, but only but 85% for non-patient-facing clinicians, which most radiologists will be considered. Advancing care information, 25% for patient-facing and not applicable for non-patient-facing. And then improvement activities are 15% for everyone. Now, I've included this 4th category cost here, which is not actually being calculated in the 2017 reporting year, so you don't need to worry about that for this year. So moving on, I'm going to do a quick live demo of a website that we've got in the works that's designed to help clinicians browse the different available measures and the different improvement activities to to select what's going to work best for their practice. So give me just a moment and I will pull that up. Okay. Just a moment. There we go. So this is the home page. You can actually access a version of this right now at qpp.acr.org, but the version I'm showing right now is a version that we've got in the works. So it's going to look a little bit different from what you can see right now on that page. So what you'll do when you load this page up, you'll go over to the Explore Measures section. You're going to be able to select from quality and improvement activities and also the advancing care information measures. Right now we've only got a demo available for the quality measures, so I'm going to go ahead and show you how that works. You'll see here we've got a list of all the measures available down the middle here, but on the left-hand side we've got these different filters that lets you narrow down which measures you want to look at. So for example, if you want to look at diagnostic radiology measures only, it's going to narrow the total down to 30. Right now you're going to be able to see some of the AC-RAD measures from 2016. Just to reiterate what Alicia was saying, these will be changing slightly for 2017. These aren't set in stone right now. But you'll also see below the AC-RAD measures, we've got the traditional MIPS measures, which are essentially the same as last year with a few additions and subtractions. So you can use this filter to narrow down by specialty, by modality, and also by which registries are available for reporting. So, and you can also sort by whether they're high priority, process measures, outcome measures, etc. And it's really easy to clear your filters up here and show all. So I'm going to just go ahead and select 6 random measures, making sure I include an outcome measure. And so you'll see here at the top, we'll show you a summary of the measures you've selected. So here I've selected 2 outcome measures, 4 of them are high priority, and that's a total of 6 measures. So because I have 6 measures and at least 1 outcome, that'll mean I will have met my reporting requirements for the quality portion. We've also got a feature here that lets you export that measure list to Excel. And that's just in case you want to save it for later and come back to it. You can click this button. So this is what that'll look like. So yeah, just a quick Excel file here with the measure numbers in column A, the title in column B, and more information about the measures in the following columns. Now we're, like I said, we're working on something like this for the improvement activities section 2. So just stay tuned for that. That'll probably be coming in the next couple months. And we're going to have the same kind of features built in for that. You know, you can add and remove different activities and export a list of the ones you've selected. And same for advancing care information. So with that, I'm going to turn it back over to Alicia, and she's going to go over how to submit your data.
Thanks, Zach. Thanks for giving an overview of each of the 4 performance categories and showing people how it kind of all pulls together. ACR is continuously enhancing our tools and our resources to provide additional assistance and a better visibility for this complex program. So this is a QCDR webinar series, so we would not want to complete this webinar without talking about how you would submit data to the ACR if you decided to use the QCDR reporting option. So you would, as a reminder, you would submit both MIPS and non-MIPS measures for successful participation, as well as attestation of improvement activities and advancing care information data will be collected by the QCDR using our NRDR portal. We collect measure data as well as the rest of this data in a number of ways. You can do a web-based entry form you can complete. We have flat file and Excel file upload. That option is available. All of our current QCDR participants have been messaged that we've updated our template for 2017 MIPS measures, as well as our specifications documents to help you collect the accurate data that we're going to need for the MIPS quality measures. Additionally, we have Web Services API as an opportunity if your group is working with any vendors or you work with billing companies that would like to assist their radiology clients in meeting the MIPS requirements and pulling together all your coding data. We have that option available. And the last option is our newest, which is for our interventional radiology registry participants. We do have the capability to use HL7 message transmission and use structure report templates that have been developed between ACR and the SIR Society to help you collect those MIPS as well as non-MIPS measures available for the IR registry. It is important to note that data submission requirements do differ for MIPS versus non-MIPS measures, and data needs to be submitted for all NRDR registries, does not need to be submitted for all NRDR registries, only the registries that support the measures relevant to your practice that you plan to use for MIPS participation. We will not go through this today, but for more information, each registry has its own process, and we have a table on our website called an NRDR data submission table, and you can see by registry what the requirements are. But please be mindful that we do not want anyone manually entering data, and we want to try to reduce your report burden, right? We're looking for new and innovative ways to get the data that we need for quality improvement as well as for MIPS reporting. So some next steps and considerations for using a QCDR: consider the measures and activities that you want to report. Be mindful of the MIPS and non-MIPS measure options if you are using a QCDR. View reporting requirements for all 4 performance categories. As we heard from Zach, if you satisfy or complete an ArtScan project, you would earn credit towards the improvement activities category, freeing up your time to focus on the quality category and give your doctors even more time to focus on that patient care. That's the primary goal. And then just be mindful that the QCDR process does start with an NRDR account. NRDR is our National Radiology Data Registries. Without an account, you're not able to see our MIPS portal and some of our other web-based tools to assist you with navigating the process. Understand data submission requirements to comply with MIPS. It's very important that for the quality category, you must, for data completeness, you must report on 50% of all patients seen for the year. That's Medicare and non-Medicare patients. So just having that wider pool of patients, you may have to make some alterations to your practice flow. So please be mindful of that. And then assess your ability if you're able to use the QCDR for MIPS reporting. A lot of our facilities are in 1 or more registries, and they have been using them for maintenance of certification or a PQI project or for some other purpose, but please be mindful that you can use it for MIPS reporting also. And then lastly, I'll just speak of the importance of kind of building your internal teams. This is a collaborative effort. Is not meant to be handled in 1 day or 1 week or 1 month. We ask that you get your practice administrator speaking with your IT, and then most importantly, having a physician champion who can kind of spearhead and help you determine which activities, which measures, et cetera. And then your vendors and your billers, we're going to be, through this webinar series, we're going to be making more emphasis on different ways to reduce the burden of data collection and make it easier for yourselves. There is ways for your vendors to integrate and interact directly with our NRDR portal. Lastly, I'll just, in here we have our MIPS QCDR timeline. If you are still making the decision of, is a QCDR right for you? Do you need to report for MIPS, et cetera? You have until October 31st to let the ACR know that you would like to use our registries and be submitting some data by that time. Most data will need to be submitted to the ACR by January 31st of 2018. There is an emphasis under MIPS, as you can see, focus on performance. So we want to make sure that we can monitor performance throughout the year and make any necessary adjustments prior to your CMS submission deadline, which from this screen would be March 31st of 2018. That's the last exact date that ACR would submit your quality data to CMS. And just to re-emphasize that you are submitting your quality data to us, but we are only submitting it to CMS one time per year, and that would be March of next year. So please be mindful any data that you're submitting to us monthly, quarterly, semi-annually, that is your data for you to take back and to tear apart. So nothing is being submitted to CMS. These are just some websites and resources that we put together in all of our presentation slides. Learn more about the quality payment program. That's where MIPS lives. Navigate our QCDR website for resources on measures, data submission requirements, upcoming webinars, et cetera. Our MIPS calculator, as well as we have participation checklists. CMS has a participation fact sheet just if you are new to this MIPS environment. And then within the last week, I've included this link because a lot of people are trying to identify, do they need to participate in MIPS or not? Some clinicians, they think that based on their group, they would be exempt from the MIPS category, and this tool is pretty helpful. You add your doctor's NPI, and it'll tell you if they are required to participate and for which tax IDs that they use. Lastly, save the date. We do have some upcoming events. Obviously, the ACR annual meeting is next week in Washington, D.C. If you are there, please do stop past our booth. We will have staff there to answer any registry questions you have, as well as macro and any other questions. Our next QCDR webinar, save the date, it is June 15th from 1 to 2, and the topic will be the QCDR data submission requirements and feedback reports, so please do tune in for that. And then lastly, if you and or your team, please take advantage of our annual quality and safety conference that we have in Boston. The dates are in October, so plenty of time to plan to participate there. And I think that's it for today's talk. We will transition to question and answer session. And then if any questions that we do not answer, we'll be sure to answer them following today's webinar. At any time, it's a full team here at the ACR. If you need to email us or contact us via phone, here is the information. So we can go ahead and get started. And if any of you have already participated in our QCDR in the past, our email has slightly changed. It's now NRDR support because we're going to be soon rolling out a formal help desk ticketing system so that we can make sure that we're responding to your questions in a more timely fashion and with the appropriate subject matter experts. So stay tuned for that.
Okay.
And so I hear people typing furiously. Are there any questions that haven't been answered already that you think other attendees may benefit from?
Let's see.
There's over 200 attendees on the line, so thank you all for your participation.
So here's one I can answer really quick. So this one comes from Catherine. She asks, to comply with MIPS, do we need to submit data to the qpp.acr.org page in addition to submitting to the registries? And no, the QPP calculator page is just a resource to help you choose measures and look at the different improvement activities available to you. It's not a method of submitting data, so sorry if that wasn't clear. That's still done through the QCDR using the data registries, just like PQRS last year.
Thank you.
This is Judy. I'm going to answer Carrie's additional question on ACI reporting requirements. Carrie asked, isn't the requirement for ACI to submit end-to-end from a certified EHR technology? How has the ACR been approved as a pass-through? So there is an end-to-end use of certified technology bonus for quality measures. That is one thing that is really not very clear at this point how that will work for using the NRDR registry. But in terms of the ACI measures, the QCDRs can report results to CMS, just as if you had in the past gone to the CMS website to attest to and report measure information or data information. So you're correct that you have to use certified EHR technology. Your CERT needs to be able to calculate the measures according to the specifications. You run those reports from your EHRs and provide the QCDR with the measure results. So if it's a measure that's an attestation, yes or no, which I think there's only one or maybe two measures that are yes or no, you would provide us with the answer to that. If it's a measure that requires a numerator and denominator, your EHR calculates that value and then you provide that information to us.
Okay, we've got a question here from, let's see, this one's from Denise. She asks, if we have to submit 50% of our Medicare and non-Medicare patients, how does this affect us if we are submitting for 90 days?
That should be a straightforward answer, but I don't think it is. For the most part, it is 50% of the cases of the services provided relevant to a measure for the 90-day period. But it depends on whether or not the period is continuous or not, and that is an area where we still need clarification from CMS. So if you submitted it from June the 1st to September 30th, continuous data, and you had a measure where you had 100 cases for Medicare and non-Medicare, then during that time period, and you submitted 50 cases, then that would be meeting the 50% requirement. But if you submitted some cases in June and then in some cases in September and some in December, not sure about the answer to that, so that's something that we will have to get back to you on.
And Judy, along those lines, we've got another question about Medicare and non-Medicare data. Terry asks, if QCDR must include patients across all the payers, not just Medicare, what data gets submitted to CMS? Does QCDR separate out Medicare patient data?
No, we don't. The records are submitted to us, and we calculate the measures based on the patient cases that are submitted to us.
And just one other point of clarification, as I mentioned in passing, because this is not a data submission webinar, but in our data templates, we just have a question of, is that patient Medicare or not? And it's a yes or no question. So that would be part of your data template that you would upload to the NRDR system. But we think for good quality improvement, I mean, if the measure is applicable to that patient, whether they're Medicare or not, go ahead and submit for them.
Okay, we've got a question here from Karen. She's asking, is the QCDR capable of receiving EHR data for ACI directly?
No. Not at this time.
Okay. Next, we've got a question from Vicky about ArtScan. Vicky's asking, how different is ArtScan from an imaging decision support tool? Can we apply expansion and improvement of our existing program be credited to ArtScan? So ArtScan is it's its own program, and again, ArtScan is not one of the CMS improvement activities. It's just a project that can be done to fulfill requirements for different improvement activities. So if you're asking purely from a perspective of how to get improvement activity credit, I would recommend looking at the list of activities and seeing what you think, expansion of your clinical decision support might count for. So you wouldn't need to have that count as ArtScan. You would just need to have it count as one or more improvement activities.
And I'll add to that a little bit. So ArtScan is based, ArtScan utilizes access to the ACR Select clinical decision support tool through a web-based portal. And you use that to evaluate cases for any project that you're doing under ArtScan, but it's not actually allowing you to order cases. So it's separate from a CDS tool that you might have integrated within your EHR or that you may use in your practice through a web-based portal. So it's separate that way, but you could do an ArtScan project if you have CDS integrated into your EHR. We have the capability to get data directly from, currently from ACR Select that's integrated into an EHR. You can submit that to us automatically and use that to participate in ArtScan and get credit for doing the ArtScan projects that way and using those for improvement activities. So to be transparent about the credit that you can receive for improvement activities doing an ArtScan project, ArtScan is, as Zach said, a program that was funded under the Transforming Clinical Practice Initiative. And there is a improvement activity called participating in the Transforming Clinical Practice Initiative. So you would think that if you were participating in ArtScan, you could get credit for that activity. However, CMS clarified that that is only if you are participating in a practice transformation network, which is another grant program, a grant award under the Transforming Clinical Practice Initiative. So the ACR and also the American College of Emergency Physicians, who also has a TCPI grant award for a similar program to the ArtScan program, worked with CMS to have approval for ArtScan for 7 improvement activities. So rather than claiming credit for the TCPI improvement activity, there are 7 separate improvement activities that CMS recognized as being accomplished by completing an ArtScan project. That was a long-winded answer. How are you?
We've got a question here from Catherine. She's asking, what is the distinction between patient-facing and non-patient-facing? And is there a report that we can share with the public? For example, do you have a pre-built report we can share, or would we have to build our own? So to answer the first part of the question, the distinction is based on a list of patient-facing billing codes that CMS released. We've got links to that information on, I believe, on our MACRA website and on the QPP website. and you can find those on acr.org. But it's based on how many of certain codes you bill. I want to say it's 100 or more of these specific codes you count as patient-facing. If it's fewer than 100, you're considered non-patient-facing. As far as a report to share, I mean, I would just look into the CMS guidelines about patient-facing versus non-patient-facing, and that should have the information that you're looking for.
And just be mindful that if you are doing group reporting, 75% of your clinicians must be non-patient facing in order for your group to be considered non-patient facing. We do have information in a table on the reporting requirements for each category at www.acr.org/QCDR. And then we're coming up on time, but there is some questions in the queue related to benchmarks, and providers as well as their practice administrators obviously want more than 3 points. If there is no benchmark, obviously it's prior year's worth of data. If there is no benchmark for the measure, you automatically get 3 points for reporting it. And then your performance, I don't want to give you a long-winded answer, but your performance is based on prior year's benchmark. So if it's not available, you will get 3 points. It will be hard to get 10 points for a measure that does not have benchmark data previously.
And that's true, and CMS has also said that they will attempt to use same year benchmarks. So, and when reporting with a QCDR, they may use the registry benchmark, but there's still a lack of detail on that, how that will work and when you would find that out. So there's a number of questions that we haven't answered yet. We are over time now. We will get answers to you, and we appreciate the time that you took today to join us, and thank you for all the questions.
Thanks, everybody.
Thanks.